Thanks for that kind invitation. I really do want to thank Midwest Surgical for inviting me. I'm quite proud and humbled to be the Harridge lecturer. And if you look back at the past Harridge lecturers, you've been very absent of urologists, so I hope is probably the first and hopefully not the last urologist I'll be able to reach out for you. What I'm here to tell you is a very long tale about how we looked at renal trauma and the nuts and bolts and dirty details of how a paradigm got changed. Some of it's data-centric, some of it's personal story-centric. And I'm going to start at the beginning, which I didn't learn about actually until about halfway through my journey. You may or may not know that after each war, World War I to Korea, there's actually an after-action report. So there's one written by the general surgeons, one written by the urologists. It's absolutely fantastic reading. And I was reading the after-action report for World War II, and it said, you know, you really don't have to operate on kidney injuries. And I was like, what? I mean, how did we know that in 1940 and didn't know it in 1999? And I would argue that these patients were probably a little bit different. You know, the ones that were bleeding to death had already bled to death on the battlefield. But I was amazed that they knew some things that we sort of forgot about, and that's perhaps a theme in surgery that recurs over and over. No talk about renal trauma would really be complete unless I just quickly reviewed the AST organ injury severity scale. You know, this is a great idea. We have it for every organ system in the body, but you have to understand it's completely artificial, right? So somebody said, well, 5 is really bad and 1 is not so bad and 2, 3, 4 kind of in the middle. But very little data supporting what that you would do, you know, put each of these in each of the categories. So grade 1 is just a simple contusion. Grade 2 is a 1 centimeter laceration. Grade 3 is a greater than 1 centimeter laceration. Grade 4 really gets confusing. This is probably the index patient we're going to talk about today, which is a significant laceration into the collecting system. But they threw in a contained hemorrhage at the vessels or a renal artery thrombosis. And grade 5 is really 2 very disparate type of injuries, which is complete avulsion, and those people obviously need a completion nephrectomy pretty fast, or a so-called shattered kidney. No fair adding up 2 of these and calling it a shattered kidney. I want these kidney parts in different counties before you're going to call it a grade 5. So I'll bring you back to the world circa 2000. So Jack McAninch for 30 years had been operating on people's kidneys, and this was the data set of almost 2,500 kidneys. So if you were a grade 1 injury, you pretty much didn't get an operation. Grade 2, you know, 20% of those people got an exploration. Grade 3, almost 80% got exploration, but you're starting to see nephrectomies. And I'm going to argue to you that none of those people should have gotten nephrectomies. And grade 4 are sort of index patient. A lot got surgery, significant number got nephrectomies. And this was the sort of thing that started to bother me about these data, because I didn't think that those people needed to get nephrectomies. Grade 5, sure. Those kidneys often quickly wound up in the bucket. But this is where we were circa 2000. I will tell you there's granularity to that data. So if it's a blunt injury, obviously all the operative rates are lower. If it's a gunshot, all those operative rates are higher, as you can well expect. So why did that data set occur the way it occurred? Well, because we knew some things. We knew that surgery was good for you. The standard of care for trauma was definitive action done quickly. And I would argue that probably no one considered the alternative hypothesis, because we knew surgery was good for you. Why would you consider not doing surgery? That would be a step in the wrong direction. And we were increasingly good at fixing you know, severe kidney problems. We were doing much more partial nephrectomies, and these can be difficult operations to do well. And I'll tell you that this paper was well received. I don't know if you know, but at the American Association for the Surgery of Trauma, not only does it have an incredibly low acceptance rate, but they do a very mean thing, and they actually have you present in the order of your ranking of the paper. So if you're ever presented last at the AST, that means you were the last paper they accepted. And we were fortunate enough to go first, maybe because we were talking about the AST organ injury severity scale, and it was picked up at the Journal of Urology, which is our big journal, and really emphasized as being a, quote, important paper. But you need to know at that same time that while there was a very giant Gulliver voice saying you need to operate on everybody, there were some Lilliputian voices out there that said, whoa, maybe you don't need to operate on everybody. There's a great paper out of Ohio, 55 people, that basically said, well, gosh, we only need to explore 16% of our blunt trauma patients, and none of those people lost their kidney. And because I had the Makinich data in my pocket, I could actually look exactly at their criteria and say, well, Makinich would have operated on 63% of those people, 11% of them would have lost their kidney. And I can tell you that about every 2.5 years, there was one paper saying, don't operate. But that's not very many papers, it turns out. Even penetrating trauma is a great paper in the 90s out of South Africa, and I'm not sure what your sense is of South African urology, but I can assure you that these are incredibly well-trained doctors, almost always via a sort of European model. They're very busy, they're very skilled, they're very good academics, and I think the average South African patient looked a little bit different. Perhaps he was walking to the hospital and they looked at him and they said, well, I don't know, he looks pretty good. Do we really have to crash him down to the operating room? He's been walking for 4 hours. Let's just look at him. And you started to get what it looked like to not operate on these patients. So they were able to manage without surgery a significant percentage of the patients, but that doesn't mean they didn't need nothing. Expectant management requires you to look at the patient and see what they might eventually need. So a few of them needed a nephrectomy, a few of them needed angioembolization, a few of them needed a rhinorrhaphy, and a few of them had AV malformations that needed to be treated. And the problem, the why we didn't pay attention to this is because of NFH. It's not from here. South Africa is very far away. It was published in a journal nobody reads, and so we just didn't really care what the South Africans had found out. But thank goodness there started to be voices coming out of the United States. I have never met Dr. Velmahaus. I really want to meet Dr. Velmahaus. He's one of my sort of literature heroes, but he says something absolutely against party line, which is that mandatory exploration of gunshot wounds is simply not always necessary. And what was happening at the same time as we were trying to figure out just how much surgery these patients needed is that lots of other medical problems were being treated expectantly. And I won't tell this population about the data for spleen and for liver, but we were starting to get smart about not necessarily crashing everybody down to the OR. One of my favorite studies, perhaps of all time, is a Velmahaus study, large numbers, and basically if you were shot in the belly, and at this time, if you were shot in the belly, I mean, I was a general surgeon for 2 years, and I knew one thing. If you were shot in the belly, by God, you need a laparotomy, you need it now. And so what Velmahaus found out is that if they didn't have peritoneal signs and they weren't trying to die hemodynamically, that basically you could observe them in the ICU, do serial exams every 6 hours, and 96% of the observed cohort never got a surgery. They just went home after 4 days of observation. Now, you got to know some of those people had small bowel injuries. Hell, some of them even had large bowel injuries. So this makes the point that really we might be overdoing it surgery-wise, and the world was starting to create an argument for less surgery on people. So what happens in year 2000? Year 2000, I finished my fellowship. I had done a NIH fellowship in the basic science of trauma. I'd done a clinical fellowship in GU trauma, and I was landing in a very fertile place. I mean, Detroit Receiving Hospital is the first hospital in the world built from the ground up to be a trauma center. I had some outpatients, and I said, well, they just need to go to the admission desk, and everybody looked at me kind of funny, and they said, we don't have an admission desk. The only way to get admitted to our hospital isn't from the back of an ambulance. So we actually had to build an admission desk. I have 4 Scudder orators at this hospital, and I can just tell you that it is a very rich place to practice trauma. And I was America's newest trauma fellowship trained surgeon, and by God, I was ready to operate on those kidneys. And what I ran into were 2 immovable forces. I believe that everyone in this room knows who Dr. Lucas and Ledgerwood are. Both of them have been presidents of this organization, and they were sweet to me, I have to say. They took me aside a little quietly, and they said, Rich, you really don't need to operate on most injured kidneys. Well, I had never heard something so wrong in my entire life. I knew that they were incorrect, and I started a research project that was fueled by the most important scientific principle possible, which is spite. And I looked at their own data so I could prove to them how terribly, terribly misguided they were in their evaluation of what people with kidney tumors or kidney trauma needed. And what we found out is that they were absolutely 100% correct. That we were probably not needing to operate on 80% of people, that we probably needed to operate on a real small fraction of people. In fact, we had to create a new term because we had this sort of idea of conservative management where you sort of tried to not operate on people, and we had to come up with the term ultra-conservative approach because we really were not operating on anybody who wasn't bleeding to death. So why was that paper important? Well, for starters, I was a Makinich disciple and a well-known Makinich disciple, and if I was saying that maybe we shouldn't operate as much as Makinich says, that got people sort of titillated and excited. I was a young academic with time and energy, and I believe the world was ready for it. I mean, Dr. Swersey said it in 1947, but I'm not sure the world was ready for it then. And the other thing is that I was lucky enough to be publishing in the United States, in the best journals, and that made the not from here problem go away, because it really was from here. And finally, the conceptual change wasn't so crazy. The conceptual change was operate or intervene quickly on those who are bleeding to death, and just take a deep breath and wait a minute on people who aren't. That wasn't that crazy an idea. I can tell you this paper was not well received. I kick myself for not actually saving the review, but it was a sort of haiku about how wrong I was. It was like something like if you were braver, you would have operated on them. If you were smarter, you would have known they needed operations. And in any case, you're wrong. But people did pay attention. And I also think that it got traction because it was easy to do. I mean, if I had a series of brain transplant patients or something, that would probably take a lot of technical knowledge to be able to adopt at your own center, but anybody could adopt this, right? They could just say, well, gosh, he's not bleeding to death, let's just watch him for 1 minute. And the important thing is it wasn't really a do versus do not do admonition. It was really just suggesting what we've been doing in a lot of other trauma conditions. So it's just look at them and see what they really need. Don't just, check a box, trauma, kidney, operate. Getting back to this idea that all you had to do was change your policy, there was at least 2 centers, both of them in Europe, so not from here, that basically just said, we don't operate on kidneys anymore unless they absolutely need it. And they basically halved their operative rate just by changing policy overnight. So it was an easy thing to do. Now, we were sure that if you didn't operate on these people, they would bleed to death, they would have renovascular hypertension, terrible things would happen. And the nice thing about European data, especially trauma data, is that it's a very orderly population. They follow up very nicely. I mean, 80% of the people you do gunshot surgeries on you don't see again. But in Europe, ones in Switzerland and ones in France, these people were following up. And they found out that if you didn't operate on them, you actually had less blood loss, not more blood loss. So they weren't bleeding to death. And the dreaded idea of renovascular hypertension afterwards simply didn't pan out. In the second study, they actually found out they spent less time in the hospital if you didn't just willy-nilly operate on them. And you again started to get this sense, well, what does it mean? Does it mean 0% intervention? No, a certain percentage needed a ureteral stent, maybe because of prolonged urinary leakage, and a few needed a renorrhea, controlled renorrhea. I'll tell you though, this idea, like all ideas, took a while. Atul Gawande says it takes 20 years for a new idea to really penetrate. And in 2003, there was a pretty big study saying that about 23% of blunt renal trauma patients were still getting surgery, and in most of those cases, they were getting their kidney taken out. And you got to know that that's a really high rate of nephrectomy for patients that really didn't need it. Circa 2005, we were asked by the Journal of Trauma to write a review on what does the literature really say about this. And I was completely amazed because in 2002, I got this really aggressive review that said, you're the dumbest guy ever. And then in 2005, these are peer-reviewed as well, even if they're requested reviews. And the reviewer from this said, this is already the standard of care. We don't need a review from it. So I somehow went in 3 years from being like so wrong to so right. And neither one one of them wanted to be published. It was very weird. And what we sort of summarized in 2005 was that if you're bleeding to death, you need an operation. We're not saying that. If you're bleeding to death, you need an operation. And otherwise, you need to observe and get more information. So you might get a CT scan. You might put a stent in if you had symptomatic or growing urinomas. Angioembolization, which is becoming increasingly competent and popular, could be used in people who are sort of bleeding, but not bleeding to death. And that open surgery was going to still happen for certain cases, not never, but also not 80% of the time. And what we got out of that is that most patients with renal injuries get away without having anything done. And most importantly, they don't have an 8% chance of unnecessary nephrectomy. So I'll give you what I think the 21st century answer is on what to do for renal trauma. So absolute indications. If you have grade 5 pedicle avulsion, you need to do what I call completion nephrectomy. So nature has already nephrectomized the patient. You just need to tie off the arteries and get the free-floating kidney out of there. If they have an exsanguinating injury, you got to do something. That might be nephrectomy. That might be renorrhaphy. In some cases, that may be angiography or angioembolization, although this is a population that I don't have to tell, you can't just write angioembolize and go to bed. I mean, these people have to be getting resuscitated. You got to be sitting in the angio suite and waiting to crash them to the OR if they do poorly. There's a relative indication for surgery or angioembolization if they're bleeding a completely arbitrary 2 units a day. And that number may be higher or lower in your hands depending on the individual patient. And there's some very relative data suggesting that patients will do better if you fix their kidney if they have a couple conditions. One is that significant devascularized parenchyma or associated enteric or parenchyma or pancreatic injury. The problem with those data is that they are old, small, and not repeated. So there is two papers, that basically say, look, if you've got urine extrav and a lot of devascularized parenchyma, that's probably not going to heal too well, and you're going to have a higher than expected complication rate, 38%. That's a 1993 paper. Has it been repeated? Nope. Here's a 2001 paper that basically matched devitalized and non-devitalized segment patients, and the devitalized segment patients stayed in the hospital longer, got more transfusions, and needed a higher number of procedures. It doesn't mean I totally crash these people down to the OR, but I certainly watch them differently, and I prepare my general surgery colleagues differently, like, look, this isn't just a fire and forget injury. This is somebody we just have to watch and wait for them to develop a complication and then fix that complication instead of going in and whacking out the kidney. Again, a good paper, so 14 patients treated conservatively, 13 patients treated with fixing the kidney at the same time that their enteric or pancreatic injuries were fixed, and they seem to do better if you fix their kidney injury. So that's 1993, never repeated. These data are so weak that they weren't even considered in recent Cochrane analysis of what to do. They just said, look, that's not data. It's too old, it's too small. So whether these things are true or not, I don't know. I can't ignore what's out there, but I think we need to know more about that. What about penetrating trauma? I mean, I think all of us would be pretty comfortable not jumping in on a patient with a renal injury from a blunt standpoint. Well, being Detroit Receiving, a significant number of the patients had penetrating trauma. We did our same sort of no-touch technique when we only operated on them if they had an indication for operation. And those patients did shockingly well. They did not have a lot of complications, and we took credit for all possible complications. So if the patient got a fever from any source, we said, fine, that's our complication. And they shockingly did well with gunshot wounds. But again, nothing that you do in science, unless you're, I don't know, Albert Einstein, actually happens in a vacuum. And there were other people saying the same thing. So Velmajos managed to have 40% of his gunshot wounds and not operate on them. Seraphinides is an interesting character. He's a Greek guy. He's also a paratrooper, which may be the coolest combination ever. And he didn't operate on about 50% of the gunshot wound patients that he saw, some of them with high velocity military rounds. And I think these data sort of matured into a recent study from South Africa. They have a lot of gun violence in South Africa. And I go to South Africa at least every year, sometimes twice a year. So I know these people well. I've been lecturing to them about this subject for quite a long time. And they had the founder effect of not operating on gunshots. And they're basically saying, look, when you're shot in the kidney, about 20% of them need to go right to the OR. About 5% of them are bleeding enough to get an angioembolization. And the remaining numbers, they do okay. And maybe you need a drain once in a while or a stent once in a while. So let's do some cases. This is a pretty easy case. This is a shotgun wound, so there's a pretty wide spread here, so this is not a close range shotgun wound. You've got an artery knocked out to the kidney, which gets everybody's attention, but that's really not a disease. And I think most people in the room would be happy to not operate on this patient. No hematoma. We're going to watch that patient. Here's the sort of next level. This is a non-con scan. Here's an entry wound here. It clips the mid portion of the kidney. There's a modest amount of hematoma there, but we're going to watch this patient and see how they do. There's no absolute indication for surgery in this case. Here's a tougher case. It's a grade 4 injury. You've got a reasonably bigger hematoma. You've got, something that looks like you knocked part of the pole of the kidney off, and you definitely have some extravasation of urine. You probably don't need to crash that person down to the operating room, and this patient did fine without anything. What about pediatrics? Well, the short answer in pediatrics is you have a kid and you're trying to do non-operative management, they're going to do the same or better than the adults. That's the sort of summary. You do have to be aware, though, that kiddos have a certain range of either having Wilms tumors, that they just fell over a little bit and knocked their Wilms tumor and blew it up, or they had congenital hydronephrosis, and that's where you get these weird cases of like what sounds like minimal trauma, but their kidney is a grade 5, rupture, and that's because they have congenital hydronephrosis, just sort of a tense bag of pus there. Now, obviously, those patients are not going to do well with non-operative management. You're going to need to take out the Wilms tumors. You almost always need to take out the destroyed congenital hydronephrotic kidney. But in general, if they don't have those things, they're going to be just like adults. There aren't that many papers that sort of say, all right, smart guy, you're not going to operate on these patients. What does that look like? So in a pediatric population, about 20% of so 80% of the people did fine. They got discharged. They never had a problem. 18% of the patients did have problems, and they needed everything up to including a delayed nephrectomy. So you do need to sort of watch them and see how they do. Renal embolization wasn't often required, but it was super helpful. The percentage of patients that you put stents in is highly sort of user dependent. Some people are just offended by urine in the abdomen and they like to put stents in, and there's really nothing wrong with putting a stent in. Other people only put stents in for symptomatic growing urinomas, and so the stent rates are sort of all over the place because they have a little bit more to do with the doctor than they do with the patient. Here's a pediatric case of a kid that had a really bizarre injury, which is that he managed to fall on his flank on a skate blade, which is hard to do. But his problem is that he's got a congenitally absent right kidney. And I can tell you that even somebody with a lot of knowledge about how to do renorrhaphy is going to inadvertently take that kidney out or lose that kidney a certain percentage of the time. So the much smarter move here was to watch this patient and not go in with scalpels, because you're still going to be 8 or 10% chance that you can't help it and end up taking that kidney out, and that kid's going to be anephric. But otherwise the kid was fine. No surgery, no harm, no foul. Here's a little kiddo, unrestrained driver, unrestrained passenger. Pretty serious injury, grade 4, pretty bad lac, medium big hematoma. No contrast in this picture, but we were able to watch that, and that kid did just fine. What about renal vascular? Renal vascular, you've got to change your mind a little bit. So what's conservative in renal vascular is to actually take the kidney out, because the less conservative move is to try and do a heroic revascularization. And so the data is absent, so it's all based on basically expert opinion, and they're saying, well, if you only have a solitary kidney and it's renovascular injury, you should probably try and fix that. If you have bilateral renovascular injury, which I've never heard or seen of, then you're supposed to repair them so they're not automatically on dialysis. This is a patient you have to squint a little bit. He's a big fellow, and I don't think they give him enough contrast. But if you look at the left kidney, there's sort of uptake. Right kidney, no uptake. There's a lot of mush here, and that mush is actually completely thrombosed right renal artery. There was a great Western trauma review. Basically, they had 88 patients, and the answer always led to nephrectomy. So when they tried to revascularize them early, they either failed immediately or it clotted off. When they tried to revascularize them at day 2 or 3, it either failed immediately or clotted off eventually, and pretty much all those patients got their kidney taken out. So I would argue to you that minimally invasive surgery for renovascular is a nephrectomy as opposed to a repair. One of the problems in one of the series that actually looked at the repairs, the average blood loss was 5 liters. I mean, I can't defend or discuss that any further than just to report you what they found, but the fact of the matter is it's kind of a big surgery to be taking on the day that you have surgery or your injury. Now, there are some series, 1982, 1980, that said there was a sort of success rate, maybe 15%, and if you are Mad Dogmatics or Dr. Feliciano or Dr. DeBakey, then you're going to have a 40% success rate. If you are not those people, you will not have a 40% success rate. You will have a 0% success rate. So what that sort of gives you is the idea that this is that same patient, by the way, who had the right renal thrombosis. I realize that's not his right side, but he got pinned between 2 cars teaching his daughter how to drive in the very hilly area of San Francisco. Just as with blunt and penetrating trauma, there's some relative indications. So you have a contained hemorrhage. It doesn't seem to be bleeding to death. You can watch that. You can repair it as well as you want. There's no data. And segmental injuries can be ignored. I get called a lot for segmental injuries because they're easy to see, but almost always we're saying do nothing. And so right now, I think we've reached the sort of end of the tail. I'm not even sure if this is readable enough, but basically number 4 of the new American Urologic Association's GU trauma guidelines basically say use non-invasive management strategies in hemodynamically stable patients with renal injury. So that's the end of a 16-year tale where I was sure of one thing, became sure of another thing, and I'm still trying to investigate what the real answer is. Let's give some take-homes. You know, I will encourage you to use angioembolization, especially in patients that are bleeding sort of moderately. The data is actually reasonably scarce. There's a pretty good North American study about stab wounds that said a significant percentage of those were treated with angiography, often successful. When not successful, they went in and fixed them. And there's a bunch of sort of tiny little case reports, stab wounds, iatrogenic injuries, pediatric injuries, that basically were able to attain close to 100% hemostasis, although some patients needed more than one angioembolism episode. And here's a pretty good example of a brisk bleed, because you got to know that's not a high volume artery there, but yet there's a lot of extravasation, and they were able to knock out just the segmental artery, leave the rest of the kidney in place, and stop the bleeding completely. Nothing I say here says you can't bring the patient to the operating room. This is an auto-pedestrian accident, big hematoma. She was bleeding. She was okay except for her kidney injury. She was bleeding, maybe lost 3 units in 12 hours, and so we brought her to the operating room. We do actually know how to do that. The kidney looks pretty bad when you first look at it, but you know, it kind of cleans up nice. The kidney has tissue factor levels which are the highest in the body, and 1 molecule of tissue factor can make something like 2 million molecules of fibrin in milliseconds, and so it really wants to stop bleeding. We put a little bit of cellulose in the wound just because we're like that. I put very superficial, just capsular only stitches and then tie over a bolster. I put titanium staples there because I was showing off to show you what this looks like versus that, and then to further show off, we got a renal scan to say, look, you know, probably you can fix these things, you don't have to remove them. I think the kidney has had the unfortunate or the misfortune of being a paired organ, and therefore removed with alacrity just because it can be difficult to fix them, but really you should fix them if you can. So the take home. If they're bleeding to death, please do something. Nothing I've said here gets you out. Haven't talked at all about ureteral injuries or renal pelvis injuries. If they have a ureteral injury, they probably need something. Minimally, they need a stent. Minimally, they need upstream drainage of the urine so their abdomen doesn't fill with urine, and probably are going to need a curative surgery at some point in the game, either acutely or later. And renal pelvis injuries that might look something like this. This is a medial extravasation of urine, and you can see the kidneys kind of decompressed, and that's because I think the renal pelvis is open here and it's just leaking the urine immediately into the renal pelvis. They almost assuredly are going to need some kind of surgery. And the other thing about this is you don't know if this is an avulsion of the ureter off the renal pelvis, and that needs to get fixed. So nothing I've told you here gets you out of operating on non-kidney things like the ureter or even the pelvis. And I will leave you with one last picture of a gunshot to the kidney, modest hematoma, so nobody seems to be bleeding to death, non-con scan, and what I tell people to do is just take a deep breath and watch this for 1 minute. And if the patient doesn't crump and you don't lose your nerve, then watch them for another minute. And put together a few of those minutes, and eventually you'll be non-operatively managing those patients with the best of them. I do want to thank my mentor for teaching me everything I know. There's Jack McAninch, for those of you who don't know him, doing something unspeakable to somebody. We do a fair amount of the unspeakable down there. And without his sort of love of data and hardcore analysis of his own work, I never would have had the data to look at. I never would have been a thoughtful person in this regard, and I certainly wouldn't be standing here. So I thank him very much. And that's what I have for you. Thanks much for your attention.